There we go. All right. And this educational event is eligible for certified nursing education credit. I'll post the link in the chat one more time to receive credit. If you've not already registered, just fill out this form. It takes less than a minute or two, and we'll be able to email your certificate of participation. And before I introduce our guest speaker, Dr. Monica Stout, I wanted to give a brief program update. Isaac Schlotterbeck is a new hire on our team and will be coordinating the program once I leave on July 1st. He received his master's in public health in Latin American studies from Vanderbilt University, and formerly worked for Vanderbilt's Emerging Infections Program. You'll be receiving emails from him in the future regarding any program updates and meeting announcements. So I just wanted to take a moment to introduce and welcome him to the team. And then our guest speaker today is Dr. Monica Stout. She is an assistant professor of medicine in the Division of Geriatric Medicine at Vanderbilt University Medical Center. Her areas of interest include curriculum development, specifically in geriatrics and wound care, and in optimization of the electronic medical record for providers. Today, she'll be presenting pressure injury stage definitions, assessment measures used in long-term care facilities, and evidence-based prevention strategies. As she's presenting, feel free to place any questions in the chat box, or we'll also allow time at the end to unmute and ask questions. So with that, I'll go ahead and hand it over to Monica. Thank you for being here today and for your time.
Absolutely. Alrighty, I'm going to try and share my screen here. Okay, I feel kind of, here we are. Woohoo! Made it. Okay, slideshow. So today's talk is about pressure injury prevention. At some point in time, I'd love to talk to you all about pressure injury treatment, because that's like my favorite. But I was asked to talk about pressure injury prevention, so here we are. So it's specific to post-acute and long-term care. This is an area of medicine that I really and truly love and enjoy. And so hopefully it will be able to give you some good suggestions about how to implement some prevention strategies in your post-acute or long-term care facility. So this is the very first time I've ever had to have a disclosure slide where there was actually something on there to disclose, but it's not for me, it's for Dr. Kripalani. So there you go. That's the disclosure that we have for today. And then of course, for anybody who wants to get nursing credit or credit hours, JC did put the link to do that survey in the chat. Okay, so here are the objectives for today. We'll cover a few other things as well, but the main things: defining the pressure injury in the stages, just so that we're all on the same page about what we're talking about, and then discussing the assessment measures, and then evidence-based prevention strategies. Okay, why should we care about pressure injuries? So pressure injuries occur in 2.5 million patients per year, and that's just in the United States. That's not across the world, that's just the United States. 60,000 patients die as a direct result of a pressure injury every year in the US, and more than 17,000 patients file lawsuits for pressure injuries every year. Not to mention that pressure injuries cost $9.1 to $11.6 billion every year, and for each individual, that would be about 20,000 to 151,000 per pressure injury. And so, unfortunately, a lot of those costs are at the expense of a post-acute and long-term care facility or hospital. And then recently, the AHRQ has decided that they're not going to be paying for any sort of hospital-acquired pressure injuries that are stage 3 or stage 4. So then the hospital itself is actually responsible for all those healthcare costs. They were talking about doing that for post-acute and long-term care facilities as well, but so far they haven't done it, thank goodness. Okay, specific to post-acute and long-term care, pressure injury prevalence in post-acute and long-term care is 28%. And that is anybody who's in a Medicare Part A SNF stay that has a stage 2 to 4 or unstageable or deep tissue injury, a pressure injury that's new or worsened since admission. And so that's the pressure injury prevalent. And then the sniff QRP measure, I'm sure everybody is aware of that, on the MDS. That is also a measure that's reported publicly on Care Compare. I'm used to calling it Nursing Home Compare, but I guess it's now called Care Compare. So these are actually publicly available data that your patients and their families can review. And so if you've got a high percentage of pressure injuries based on this QRP measure, then it is possible that you may unfortunately have patients and families that don't want to come to your facility. And then, of course, we should always care about appropriate patient care too, and taking care of people. Okay. All right, so just so that this is just really so that we're all on the same page as to what a pressure injury is. This. So this is the definition from the National Pressure Injury Advisory Panel. And that's the American version. There is also a European Pressure Injury Advisory Panel and then a Pacific one as well. So, new definition. Pressure injury is localized damage to the skin and underlying soft tissue, usually over a bony prominence. The injury can present as intact skin or an open ulcer and may be painful. The injury results as a result of intense and or prolonged pressure or pressure in combination with shear, and then the tolerance of the soft tissue may be affected by these various things mentioned. The reason that they changed it from pressure ulcer to pressure injury was to incorporate stage 1 and deep tissue injuries, because these actually have intact skin, and so they wanted to make it more of a broader definition instead of just an ulcer, which is truly an ulcer is an open wound. These are the stages of pressure injuries. So, stage 1, we're all kind of familiar with that. It's the non-blanchable erythema. Stage 2 is partial thickness skin loss with exposed dermis, so it's not down to the subcutaneous tissue. Stage 3 is full thickness, which is down to the subcutaneous tissue, usually adipose tissue is what you're going to be seeing. Stage 4 is full thickness skin and tissue loss, so you can see fascia, tendon, muscle, ligament, cartilage, or bone in the wound bed. Unstageable means that you can't really see the bottom of the wound bed. It's obscured by eschar or slough. And then a deep tissue injury is where it's a dark purple discoloration. You assume that there is tissue damage there, and then, but it's still intact skin. So that's kind of our definitions. So risk factors. What are the risk factors for all of these pressure injuries? So we divide them into intrinsic factors and extrinsic factors. So intrinsic factors are the things that are going on with the patient. So, you're all familiar with the Braden scale. So this incorporates some of that. But just to think about what may actually be involved with their limited mobility. Could be their current crisis, like sepsis, delirium. They're not really mobile. They have low blood pressure. They may have severe osteoarthritis that doesn't allow them to move. They could have had a stroke. Sensory loss. If you have diabetes with neuropathy, or you have sensory loss from your stroke, you just are not able to feel the pressure when you're sitting. And then, of course, other illnesses that reduce tissue oxygenation and or the immune response. So diabetes, that actually limits your immune response to the wound. It keeps wounds open for longer. If you have any sort of arterial disease, that can also cause a lack of oxygen delivered to the tissues. COPD. If you have COPD and you're hypoxic and you're not being adequately treated with supplemental oxygen, you are reducing the oxygen to your tissues. And so wounds are going to be much harder to heal if you have COPD. Same thing with congestive heart failure. So particularly people who have an ejection fraction that's really low, because they really are not able to deliver the blood flow to the tissue that needs to be healed. So you really have to evaluate a lot of these intrinsic factors, and this is something that providers, nurse practitioners, MDs, as well as obviously nurses too, have to think about and assess when they are seeing a patient, especially if they are high risk for pressure injuries or if they already have one. Here's the extrinsic factors. So we talk about pressure, so standard mattress versus, wheelchair seating that you don't, inappropriate wheelchair or inappropriate cushion. Friction and shear, they finally incorporated friction and shear into pressure injuries. Moisture, of course, incontinence. So the pH of fecal incontinence is actually much worse than the pH of urinary incontinence. So people who have fecal incontinence, it's actually much worse, or much more of a risk to have that. So definitely fecal incontinence is something that needs to be addressed, and patients should not be sitting in their briefs with fecal incontinence. And then, of course, nutrition. So if you have some sort of malignancy or an infection or a critical illness that really is taking up more nutrition than you would normally use, or you really have low protein, a lot of those lovely geriatric patients, they just don't eat a lot of protein. They're busy eating their sweets, their cinnamon rolls or their candy, because that is what they can taste. Actually, when you're a geriatric patient, you lose a lot of your other taste buds besides sweet taste buds. So that's why older adults tend to eat a lot of sugar. However, this is not protein. And so that is a constant struggle, in terms of getting them to eat enough protein. Okay, so in terms of risk assessments, like what you're going to be using actually in the nursing home, there's really only two that have been validated and are used frequently. So of course, Braden. I feel like almost every single nursing home in the US uses the Braden score. There's also this Norton score. So the Norton score was developed in 1962 in England. Braden was developed here in the US in 1988. So clearly we've been using these for a really long time, and they seem to really assess risk well. Of course, I do want to just say that it is worth looking at all of the other things that we talked about, such as the intrinsic factors, because really Braden is assessing more so for extrinsic factors as opposed to intrinsic factors. So you have to be on an interdisciplinary team so that the providers also can talk about the intrinsic factors, and then everybody else can also talk about some of the extrinsic factors and also the intrinsic factors that they've noticed. So really, in terms of what's most used in the nursing home, it's the Braden score, and it works well. The only thing that I would like to point out at this time is that, see that total score at the bottom? It says total score of 12 or less represents high risk. However, if you look up at the top, it says mild risk, total score of 15 to 18. So as a wound care, I guess I call myself an expert, but a wound care expert, the current suggestion is to actually consider anybody high risk who has a Braden score of 18 or less. So it captures more patients than using the high risk score. And so even though Braden, associates it severe, high, moderate, mild, if you consider anybody who is at any risk at all here, you're going to capture more patients. The Norton scale tends to capture more patients as high risk, because the score there is less than or equal to 14. But I feel like we just don't use it very frequently here in the United States. And so getting people used to a different score that's more sensitive isn't really helpful. So the Braden score, it is, but suggestion is to start using less than or equal to 18 as your benchmark instead of 12. Okay, prevention measures. So I wish I had a magic, this is what we're, all going to be doing, and it's all new and fantastic, and it's going to revolutionize nursing home care. But really, it's the basics. So the first thing, to do is maximize treatment of the patient's medical conditions. So if you have low blood pressure, your risk of having a pressure injury is much higher. because the way pressure injuries occur is the pressure essentially overwhelms the pressure of the little capillaries down at the base of the tissue. And so if you have low blood pressure, your capillary pressure is much lower, so it's much easier to have a pressure injury. Diabetes, of course, puts you at great risk, not only for sensory issues or perception issues, but also because your immune system is compromised in diabetes. So you really can't keep your skin as moisturized as you normally would. There's greater risk for infection getting in. And so really diabetes is it's a difficult one to treat, but it really needs to be treated well in order to prevent pressure injuries. Respiratory illnesses, I already kind of went on about COPD and hypoxia. And then of course, medications. So medications that could be a problem in terms of pressure injuries would be immunomodulators such as prednisone, hydroxychloroquine, methotrexate. All of these can actually put patients at risk for pressure injuries. And then also ones that create bruising and bleeding. So obviously we have to use them, in terms of AFib or blood clots, but all of the new anticoagulants, and then warfarin in particular, usually is a high-risk medication in terms of bleeding, bruising. So of course you want to make sure that the medications are really appropriate for the patients. And if you can reduce some of these meds, that is always helpful. So number 2, nutrition consultation needs to be done early in the patient's post-acute and long-term care stay. I think a lot of nursing homes already have, standard practice. The dietitian sees patients within a day or two of the admission. So that is helpful. The recommended intake is 30 to 35 kilocalories per kilogram of body weight daily for those who are at risk or those who have a pressure injury. And then it really should be through their diet to get those calories in. However, you can use high calorie, high protein supplements if you can't accomplish it with nutritional intake alone. There was a recent evidence-based study, randomized controlled trial, that incorporated a supplement containing arginine, L-arginine, zinc, and then antioxidants. And that supplement in particular did seem to prevent pressure injuries and also to have faster healing times on people who had pressure injuries. And so that might be something to consider as well. There are various supplements like this, Juven, Arginade. Of course, you can kind of cobble together an L-arginine supplement plus zinc, antioxidants. That one's a little bit harder. I think Juven has antioxidants in it. So there are options. I think a lot of people will use like Prostat, but Prostat's more like protein. It's not this supplement that contains arginine, zinc, and antioxidants. Frequent repositioning. So the recommendation is actually to reposition every hour when a patient is sitting. So if they're in a wheelchair or a recliner, they need to reposition. So a way to do that would be to stand them up for 30 seconds every hour, or to turn them, or to place a pillow on one side versus another. But it's actually every hour, and that's really hard to do in a post-acute and long-term care setting. And then in bed, the repositioning recommendation is every 2 to 4 hours. They actually did a randomized controlled trial that showed that there wasn't really a difference between 2, 3, and 4-hour turns in nursing homes. Of course, here in the US, our standard of practice is every 2 hours. And so, in terms of getting ahead of any sort of surveyors or implementing a pressure injury prevention program at your facility, I'd say probably stick with the every 2 hours. But just so you all know, in Europe, the standard is every 4 hours because of this randomized controlled trial that didn't really show a difference between 2, 3, and 4-hour turns. And then we already kind of talked about the management of incontinence. Fecal incontinence is worse than urinary incontinence, but essentially it damages those tissues on the buttocks and the sacrum, and it makes it so much more susceptible. So, implementing programs such as timed toileting, or, CNA rounding, making sure that briefs are dry and there's no fecal incontinence. You need to manage it well. And then, of course, pressure redistribution systems. So that's my next slide here. So this is a very busy slide. I am sorry. I don't usually like busy slides, but I wanted you to have this information. And so there's all different types of mattresses, of course, but also I wanted to point out that the pressure redistribution system also includes wheelchair cushions. So really there's no difference between the kinds of wheelchair cushions in terms of prevention, which one works better. And then there's really not much evidence in terms of treatment of pressure injuries using wheelchair cushions. But it is important that if somebody is identified as a high risk for pressure injury, that you might want to go ahead and make sure that they have some sort of wheelchair cushion, be it foam, gel, air, or a combination. Then in terms of the mattresses, so Medicare has the various different types of mattress, group 1, group 2, group 3. There really doesn't seem to be much of a difference in terms of pressure injury prevention between all of these different kinds of support surfaces. The only thing that I would say is that for the air fluidized mattress, in terms of treatment, it does seem to work better than the alternating pressurized mattress. So if you have somebody who already has a pressure injury and is of course at risk for more pressure injuries because they have a pressure injury, air fluidized mattresses would be nice, but it is very, very difficult to get in a post-acute and long-term care setting. I do think some LTACs have them, but I don't know of any nursing home that does. But please feel free to correct me if I'm wrong. If you have air fluidized mattresses at your nursing home, you let me know. Okay, so how can a comprehensive pressure injury prevention program be implemented? So I assume a lot of you are familiar with what are called PDSA cycles, the Plan, Do, Study, Act. And so really this is probably the best way of going through pressure injury prevention in your facility. So it's kind of simplified. I'll talk about some other kind of practical interventions next slide, but I want you to think about this in terms of getting your facility on board with any implementation that you make, even if it's just simply changing one thing in terms of your pressure injury prevention protocol. You still want to go through this cycle here. So in terms of planning, so you want to assess who are the stakeholders, who actually will care about you improving pressure injury prevention at your nursing home. So that would include the administrator. They will be on board, the director of nursing, the wound care team. But then also you should really involve the LPNs, the RNs that are on the floor, the CNAs who are doing a lot of this work and really are so integral in pressure injury prevention. So you have to get this group of people, a team together, to work on pressure injury prevention program. You want to gather what your current information is. What is your current plan? Does it meet best practice standards? If it doesn't, how can it be improved? And you identify a few areas that could be improved for the first cycle. And so then you go ahead and you implement a few of the alternatives. Then you study, was there actually an improvement in terms of your pressure injury prevention program? Were there less pressure injuries during the period of time that you've been implementing this change? And then if it has, then you standardize that practice. Then you can go back to the beginning, go back to the team and say, okay, how can we do this even better? And you may implement a few more things and then go through the whole process again. But really, it needs to be a continuous process. Recommendation is really to go through this about every 3 months due to staff turnover in nursing homes. And then also really just to re-engage the people who are there and get them excited about actually doing pressure injury prevention. Okay, practical interventions. So again, sorry, busy slide. So easiest thing really is to start using Braden of less than or equal to 18 as your cutoff for high-risk individuals. And then once the patient is identified as high risk, you want to implement regular skin assessments. In the hospital, it's recommended to be a daily skin assessment. However, I really just don't see that happening in the long-term care setting. but it has to be more than once a week, because really patients who are not high risk, really it's just a weekly skin assessment for them. But you always have to repeat the Braden to see if there's anything that has changed in the last week, and if they do become high risk, then you would want to include them in more frequent skin assessments. A thought would be, maybe Monday, Wednesday, Friday, make it a standardized practice in the nursing home. Like, okay, every Monday, Wednesday, Friday, we have to do a skin assessment on high-risk patients. And it would be nice, of course, in the EMR if there was something that, said Braden score at the top, to kind of trigger nursing staff to remember, okay, this is what we have to do for these patients. So instead of, just kind of the standard registered dietitian reviews the chart, does the intake for all patients, it would be good for them to be notified that it is a high risk patient. So as soon as the Braden assessment's done, there should be some communication with the dietitian saying, hey, this is a high risk patient, their Braden score is this. And so, then the dietitian can, modify what he or she would be doing for that particular patient. Therapy should also be notified of high-risk patients as soon as Braden assessments are completed. So, it may be difficult, like if they're a Part A stay, they're going to be assessed by physical therapy anyway. So physical therapy then would be notified, hey, they're high risk for pressure injury, and they can include some of that in the therapy that they're doing, occupational therapy too. But if this is a long-term care patient, that you're busy doing the Braden assessments weekly, and then all of a sudden they become high risk, you might want to refer to restorative therapy, in terms of bed modifications, bed mobility, that sort of thing. But therapy in general should be notified. You might want to include the pressure injury risk assessment as well as current pressure injuries into care plans, reviewed weekly with the multidisciplinary team. I think a lot of times we talk about wounds, but we don't always talk about pressure injury risk. And so that might be something to bring up. Okay, their Braden score is this week. This one would be kind of hard, but you could consider placing high-risk patients or patients with current pressure injuries in a specific unit or hallway, or you could implement a turn team, 2 staff members who are always ensuring that high-risk patients are turned every 2 hours. It's a little bit harder to do that, but in terms of patients who have immobility, who are on vents, that they're usually in their own unit. So in those cases, a turn team really might be helpful for ventilated patients. Another suggestion would be to educate patients and patients' families. This is what we do in medicine all the time anyway. We're constantly educating patients. And so, but a lot of patients and a lot of patient families don't understand. They come to me and they're like, how did this happen? I don't get it. I was just in the hospital. Shouldn't they have been taking care of me? I was at the nursing home. They're not doing a good job. They're complaining because they don't understand what has actually happened. So if you, educate them about the risks, you are a high risk patient for this disease, this wound, this pressure injury, and this is probably what happened. Then they may not be as excited about blaming everybody for what happened, but understand more of why it occurred and then what they can do about it. You want to empower your patients as much as you possibly can. Obviously, patients with dementia are a little bit harder. They're not going to understand any sort of handout you give them on pressure injuries. But at the same time, their family members, may be there every day. Daughter comes to visit every day. You're making sure that she's also contributing and helping her parent turn or reposition whenever, she is there. Or a son, I don't mean to be say, daughters are there more frequently than sons. But so for both, families can definitely be involved in this program. Whatever you end up doing in terms of pressure injury prevention program, this might be a good option. You could do a handout, or even the providers, if the providers are notified, that this is a high risk patient with the Braden assessment, they can also educate patients and families when they see them for the admission. Then probably the most time-consuming but lovely setup is the AHRQ On-Time Pressure Ulcer Self-Assessment Toolkit. So this is actually a set program that has facilitators who are trained, and they can essentially help you evaluate your organization's readiness for change, set up a team approach, assess your current practices, identify ways to implement best practices, measure your success, and then foster sustainability for a pressure injury prevention program. It's really a lovely, very comprehensive, includes a lot of the things that we've already discussed, and it's all right there for free on their website. And so, but it is kind of extensive. So there's all sorts of self-assessments that you have to complete, and trainings that you have to do. Really, it has been shown to be pretty effective. Okay, this is also just kind of a brief example of a pressure injury protocol, also from AHRQ's website. So it kind of starts with a skin assessment. You do it on admission or readmission. And then let's say, okay, you document all the skin issues. If they have skin issues, yes, then you report to a provider. One of the medical malpractice cases I worked on had a pressure injury that was discovered, and then the provider wasn't notified until 4 days later. And so that nursing home had to pay out. And so this is a very important part of any sort of pressure injury protocol. If you do have abnormal findings on your skin assessment, the provider should be notified. And then the provider can also implement some changes, of course. And then this one includes reassessing skin daily, but as we discussed, it might be hard to do that in the nursing home setting. And then you can, there's all sorts of kind of interventions on this pressure injury protocol, and it is on AHRQ's website. So it's kind of a nice, comprehensive overview of what can actually be changed, and this is an example of what facilities could do. So it might be something to model any sort of pressure injury prevention program that you might be implementing after. Okay, these are all my references. There's a lot of them. But I would like to open up for questions. I wanted to make sure I had a good amount of time left for that.
And anyone, if you have questions, feel free to put those in the chat, or feel free to unmute yourself at this time.
I personally really appreciated this. This was really informative, and a lot of information I didn't know, even as a provider previously in a nursing home. So I really appreciate this. Thank you.
You're welcome.
While folks are thinking about it, I actually had a question that came to mind. Really appreciate this overview of best practices and just your expertise in this area, specifically in the long-term care arena. And I just was wondering, there's several different interventions that you talked about, and assessments and different areas for folks that they could possibly work on. So if a facility was wanting to take really their first step, starting their first PDSA, is there something that you would say, oh, this is a easier ask, or a great first step for a facility to potentially look at?
Yeah, I would say that notifying the different teams of the Braden score is probably your easiest thing to do, because you already have to do the skin assessment on admission. And so I feel like a lot of nursing homes, the nurses do the assessment for admission, but then it never really goes anywhere. There's no notification tool. So that might be the easiest thing to do, is just, okay, we had 3 admissions yesterday, and 2 of them had high risk Braden scores. And so those 2 patients just get, you just notify the dietitian that, hey, they scored high on their Braden. And so maybe you could think about that in terms of what your nutrition plan is going to be. So that might be an easy one to do. Really just making sure everybody's on the same page and notifying everyone that this is a pressure injury risk patient.
Thank you. I appreciate that. Anyone else have questions that have come to mind or practices in your facility you'd like to share?
Quiet group today.
Dr. Stout, one thought or question is, as we work to maybe improve educating our residents and their family members about pressure ulcers, are there any areas that you've steered people to for like easy handouts or references to aid in education, or any good resources that you know of?
Yeah, so of course the National Pressure Injury Prevention, or NPIAP, they have great resources. So they have patient resources as well as provider resources. I haven't looked at their patient resources in a little while, so I'm not sure. I'm assuming they're as up to date as the 2016 new guidelines. But the other thing too is that there are like geriatric books, that have patient handouts on pressure injuries. And then I'm trying to think if there would be something else, but usually I use the NPIAP. They usually have the best data and patient care handouts.
There was a question put in the chat. I'll just read it aloud. You mentioned the turn team. Any other ideas for more immobile patients, including those that are COVID isolated, vent or similar patients that facilities could try for a possible prevention plan? That's a great question.
Yeah, it is very difficult in terms of dealing with immobile patients. It probably the best thing is to make sure that there is a pressure reducing surface. And so a lot of times vent patients will be on, a specialized mattress, but it kind of depends if it's a group 1 versus a group 2. So if they are on a group 1, then you could consider, switching everybody on the unit to a group 2 mattress. And like I said, group 3 is a little bit harder to do. And then the other thing too is vent patients are so difficult in terms of their respiratory status. But as I talked about with COPD, you really need to make sure that their oxygenation levels are appropriate. So you have to involve the providers and the respiratory therapists who are managing vent patients so that they are also aware that the oxygen levels really need to be greater than 90 and really very monitored, and make sure that they are perfusing and getting oxygen to the rest of their tissues. So, but it's hard to deal with the more immobile patients.
Thank you for these great questions. Any others that have come to mind? Just want to give another opportunity for folks. Seeing that I don't see anything in the chat, I just want to again thank you for your time, Dr. Stout. This is very informative, and like I said, this session was recorded, so we'll be distributing the recording to the folks on this call and folks on the invite in case that you want to refer to this later. So really appreciate the information and for your time, Dr. Stout, and for everyone joining us today.
Thank you very much for having me.
Thank
Yeah.
you.
Of course, thank you.